Hello everyone, welcome to this video where we study parasitic infections of the skin. So starting with scabies, which is caused by the mite Sarcoptes scabiei var hominis, also called as the itch mite. It spreads from one another through close personal contact as well as shared belongings, which are called as fomites. So you often get scabies in people who are living in overcrowded homes or where there are a lot of people living in a small space. And in terms of water-related diseases, it is a water-washed disease. That is, there is lack of water to maintain sanitation. So this is a water-washed disease. When the mite first comes in the body, the different antigens of the mite induce a delayed type hypersensitivity response, and the symptoms take about 4 to 5 weeks to develop. So remember, the incubation period after the first exposure is 4 to 5 weeks. In case of a reinfection, memory T cells are already present in the body. Symptoms appear within 2-3 days. The classic history that the patient comes and gives us is pruritus. It is an itchy condition, and the pruritus is more when the patient sleeps in the bed, puts a blanket on their body. That is, itching is more at the night. So this is called as nocturnal pruritus, a very important hint towards scabies in your questions. Secondly, family members may have the disease at the same time, so you may get a family history positive. What are the lesions when you examine the patient? You see there are multiple papules and nodules as well as these scratch marks, which are called as excoriations. So patient presents with multiple papules, nodules and excoriations. The classic image that you get in the exam is that of lesions present in the finger webs. So these are multiple papules present in the finger webs. Now, papules, nodules may be present in so many conditions. How do you know it's a case of scabies? You look for the pathognomonic lesion. The pathognomonic lesion here is the burrow. What is a burrow? This is a linear wavy tunnel in the skin. This is a linear wavy tunnel in the skin in which the mite lives. Most common site for burrow are the finger webs. And in the epidermis, it is present at the level of the stratum corneum. So remember, burrow is the pathognomonic lesion of scabies, most commonly seen in the finger webs, and it is present in the stratum corneum. In the distribution of lesions in adults, you see that the lesions are present below the neck, and they are present commonly on the finger webs, the wrist, the cubital fossa, underarms, trunk, as well as the genitalia. A circle can be made through these common sites. This pattern is called as the circle of Hebra, and remember, classically in scabies, the lesions are seen in this distribution. Now, the diagnosis is mostly clinical, depending upon the history as well as the examination. Sometimes a KOH examination can be made from the burrows in case of doubt. You see the mite, its eggs, as well as the feces, which is called as scabella. When you look at the mite, you see that it is a round to ovoid body. So it has a round to ovoid body with 4 pairs of legs. You see 2 pairs are present anteriorly while 2 pairs are present posteriorly. So in total, this mite has 4 pairs of legs. In the treatment, very important to treat the family, then wash the clothes and the laundry that have been used in the last 3 days, antihistamines to counter the pruritus. In the medical management, we can use both topical and systemic drugs. Topical drugs include permethrin, lindane, crotameton, benzyl benzoate, precipitated sulfur, while the systemic drug is ivermectin. Here, the drug of choice for scabies is permethrin 5%. So remember, the drug of choice is permethrin 5%. It is a neurotoxic pyrethroid, blocks the sodium channel in the nerves, causes a delayed repolarization and thus paralysis of the mite. It is given in 2 applications, 1 week apart. Ivermectin, which is the oral drug, is binding to the glutamate-gated chloride channels, causes hyperpolarization and thus a spastic death of the mite. So remember, permethrin causes paralysis, while ivermectin causes a spastic death. Given again in 2 doses, 1 week apart, at a dose of 200 microgram per kg stat. Now, there are certain other special forms of scabies that we need to know. These are the infantile, Norwegian, and the genital scabies. In infantile scabies, the lesions are present all over the body. This case, the question might always mention that family history is present. Then there are itchy lesions all over the body. But the classic lesion that takes you towards scabies are these vesiculopustular lesions on the palms and soles. The classic lesion, which may be given in the text, it may be given in the image, are vesiculopustular lesions on the palms and soles. So these are classic lesions of infantile scabies. Next, we have Norwegian scabies, which is also called as crusted scabies. It is the most severe type of scabies seen commonly in people who may be suffering from AIDS or immunosuppressed due to other causes. Now, when you're immunosuppressed, what happens? There is no immune response to the mite. There is no delayed type hypersensitivity. Patient does not itch. So there is no itching here. Now, in scabies, in a normal scabies, there are just 10 to 12 mites which are present on the body of the patient. So remember, in normal scabies, there are just 10 to 12 mites present on the body. But here, due to no itching, you don't scratch the mite of your body. They keep proliferating and rapidly increase in number. So here you have millions of mites on the body of the patient. Contrast this with only 10 to 12 seen in normal scabies. And what you see are these crusted scaly lesions on the body of the patient, because of which it is called as crusted scabies. In the treatment, we use permethrin with ivermectin as well as a keratolytic agent to reduce the scaling on the surface, that is salicylic acid. So remember here, both oral and topical management is used together. Nodular scabies, the patient has these persistent nodules which are very itchy. So these are persistent itchy nodules which may remain on certain areas of the body even after treatment. This is called as nodular scabies. Most commonly, it is seen in the genital. So next we come to pediculosis, which happens due to the louse. There are 3 different types of louse which cause 3 different infections. The first we have is Pediculosis humanus capitis, which causes pediculosis capitis, infection of the scalp. Then Pediculosis humanus corporis causes pediculosis corporis, which is involving the body. And then we have Thyrus pubis that causes thyriasis. The term pubis here tells us this is infection of the pubic area. When you look at the lice, you see that they have a thin, long body with 3 pairs of legs. So differentiate this from the scabies mite. This has 3 pairs of legs. And this is the image of the pubic louse, that is Thyrus pubis. It has a shorter, broader body with more curved claws. It has sharply curved claws which let it hold the pubic hair better. Because of this, it is also called as the crab louse. Now, coming to pediculosis, this spreads by close personal contact and even fomites. It is also a water-washed disease similar to scabies. Here also, when the louse first comes on the scalp, it drinks the blood. The salivary antigens come in contact and cause a delayed type hypersensitivity response, which takes 4 to 5 weeks to show. So remember, these are the similarities between scabies and pediculosis. The spread, type of disease, hypersensitivity, and the incubation period are similar. Coming to pediculosis capitis, which often presents in school-going girls with long hair as pruritus on the scalp. Now, when you keep itching, you may also create scratches which can get secondarily infected with the bacteria. So this also presents as a recurrent scalp pyoderma. In fact, pediculosis is the most common cause of recurrent scalp pyoderma in schoolgirls. When you examine the patient, you may see that the regional lymph nodes are enlarged, which includes occipital as well as cervical lymph nodes. How do you make a diagnosis? You see adult lice on the scalp as well as their eggs. So on examination, we see adult lice as well as their eggs, which are called as nits. Next, we come to Pediculosis corporis, which is often seen in people who are homeless destitutes, because of which it is also called as vagabond's disease. And here the louse lives in the seams of the clothes of the patient. So these are homeless people, they don't take bath, they don't change the clothes. So the louse keeps living in the clothes, it comes to the body, drinks the blood, goes back to the clothes of the patient. This is Pediculosis corporis. Then in Pediculosis pubis, also called as thyriasis, it is caused by the crab louse, and this is often a sexually transmitted disease where patient presents with itching in the pubic hair. When you examine, you see these small bruises in the area. These bruises are called as maculae caeruleae. So a classic finding in pubic pediculosis is maculae caeruleae, which are small bruises in the pubic area. When the louse drinks the blood, the saliva of the louse has an anticoagulant. When it enters the blood, it causes a bruising. So you see these blue colored bruises, that are maculae caeruleae. In the treatment, obviously treat the contacts, give antihistamines to counter the itching. Medical management topically is done with permethrin used at a concentration of 1%. So permethrin 1% lotion is used here. Systemically, ivermectin can be used, but remember in Pediculosis corporis, you also have to treat the clothes of the patient. Either discard them and incinerate, or if you have to reuse, wash at high temperature water. So treatment of clothes is mandatory for Pediculosis corporis. Permethrin used at a concentration of 1% is given as 2 applications, 1 week apart. Apply on dry hair for 15 minutes, rinse, follow it up with knit combing. Ivermectin, again given in 2 doses, 7 days apart at a dose of 200 microgram per kg stat. Another oral drug that we can use here is an antibiotic, that is cotrimoxazole. Next, we come to Demodecosis. This is a mite which is Demodex folliculorum and Demodex brevis. It is a long body here, as you see, of the mite, lives as a commensal in the pilosebaceous unit. So remember, the Demodex mite lives as a commensal in the pilosebaceous unit. It can cause a disease of its own, or it can be associated with pathogenesis of certain diseases. It has been found to have a role in causation of rosacea as well as exacerbations in atopic dermatitis. When it causes the disease, this is called as demodecosis, which presents as erythema as well as multiple papules and papules on the central face. So this is called as demodecosis. Treatment here is with metronidazole gel applied topically. So next we come to certain migratory infective skin conditions, which includes cutaneous larva migrans and larva currents. Cutaneous larva migrans is caused by Ankylostoma brasiliensis, which is the dog hook worm. And here the patient may give you history of walking barefoot in soil, sandy or beach areas. Thus, the most common site where you find the infection are the feet. And remember, humans are an accidental host, so they are the end host for this worm. And the larva, even after it enters the skin, it cannot go much deeper because it cannot penetrate the basement membrane of the skin. So it is limited to the epidermis. This is limited to the epidermis, because of which it forms this superficial tract in the skin. Clinically, it presents as a linear serpiginous lesion. So remember, it is one of the classic causes of serpiginous lesions. You see this tract here, looks like a snake. So this is a serpiginous lesion. It is red and it is pruritic. Treatment can be done with albendazole or ivermectin. So next we have is larva occurrence, which is caused due to Strongyloides stercoralis, also called as the racing larva. Here also there might be history of contact with soil contaminated with animal feces. The lesions here are classically wheals, which are itchy. They are rapidly migrating, which is due to the intradermal movement of Strongyloides, and the classic sites are perianal, thighs, and the trunk. So these are the classic sites for larva occurrence. Treatment is with albendazole or ivermectin. Then we have the calabar swellings, which are caused by the loa enters the body via the deer fly, and here you see lesions which are itchy, non-painful swellings on the skin and can be associated with eosinophilia in the body. Sometimes in the conjunctiva you may see it due to its migration in the eyes. The treatment for which is diethyl carbazine. Now coming to trypanosomiasis, which has two variants, the African and the American forms. The African trypanosomiasis is caused by Trypanosoma brucei, the vector for which is the tsetse fly, and it is also called as sleeping sickness. It is of two types, the East African and the West African forms. In the West African trypanosomiasis, in the early stages, it is in the blood and the lymphs, which is called as the hemolymphatic phase, while in the later stages, it is in the CNS symptoms that are predominant. It is called as the meningoencephalitic phase. A classic sign on the skin that we see are the posterior cervical lymph node enlargement. This sign is called as the winter bottom sign. So this is called as the winter bottom sign, which is seen in West African trypanosomiasis. Now coming to the American form, which is caused by Trypanosoma cruzi, the vector for which is the redwood bug. It causes a disease which is also known as Chagas disease. Now in the American trypanosomiasis, in the early stages, it is the blood and the tissues that are involved. Patient presents with flu-like symptoms. Here we also see a unilateral painless edema of the eyes and the palpebrae. So in the periorbital area, you see edema. This is called as the Romana sign. This is called as the Romana sign. While in the chronic phase, we have cardiac conduction defects, megaesophagus, and the patient can also present with achalasia.